welcome to the APAPP podcast. I am Corinne Young. I'm the president and founder of the Association of Pulmonary Advanced Practice Providers. And today I have with me two great guests. You probably have seen them if you follow APAPP on any of our channels. They've been speaking for us at our conference and they've spoken for us on other podcasts. But I'm going to start with Amanda Mixon. She's a PA who's been practicing for the last 18 years, starting out first in private practice in Michigan. She then went on to be the first PA in rheumatology at the rheumatology department, at Northwestern University in Chicago in their scleroderma clinic, which we're going to be talking about scleroderma today. She then moved to Colorado and has been working in the rheumatology department at the University of Colorado in Fort Collins ever since. And in her spare time, co-founded RAP, which is the Rheumatology APP Association, which is much like our APAPP Association. And then we also have joining us today, Jessica Glennie. She is a nurse practitioner who's been practicing for the last 10 years in the ILD clinic at the Cleveland Clinic in Ohio. And she's also a member of the APAPP ILD subspecialty committee. So if you want to hang out with her, that's a good committee to join. She also is featured in our regionals that we've been bringing information to you guys. We're in Cleveland, doing a regional meeting with Jessica in September 2025, and then we're going to have some in 2026 as well. So welcome both of you to the podcast.
Thanks, Corinne.
Thanks for having us.
Absolutely. All right. So Amanda, we're going to start with you. When we're talking about scleroderma, ILD related to scleroderma. So walk us through the scleroderma part first. So how do providers initially identify scleroderma?
Yeah, it's interesting because the longer that you do this, you know, when somebody with scleroderma walks in, you kind of know just based on kind of what they look like, what their skin looks like. So it is one of those diseases that's, I think, a little bit easier to characterize when that patient comes in. But really, it's this multi-system disease that is characterized by widespread vascular dysfunction and progressive fibrosis of the skin and internal organs, which is obviously where you come involved because the lungs are one of the most common places that are impacted. So really, you think about this thickened, hardened skin. So patients really lose the fine wrinkles of their fingers and really it can extend up the body. And that's kind of how you can tell. So it really has this shiny appearance to it. There are two types of scleroderma, limited cutaneous, which is otherwise known as crest syndrome, and then diffuse cutaneous. And really that limited is the skin involvement. It's really limited to the hands, the distal forearms, a lesser extent, the face, the neck. And in terms of that crest syndrome, which is an older terminology, but a lot of people still use it, it's really this acronym for some of the characteristics of limited scleroderma. So calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, and then these telangiectasias that patients can get. It's associated with a type of antibody called centromere antibodies. So most of these patients will have those centromere antibodies. And a later complication associated with it is pulmonary hypertension. And so that's something that we're always screening for. Diffuse cutaneous, as it suggests, is kind of this diffuse skin involvement, the chest, abdomen, upper arms, shoulders. It's interesting because these patients will often really progress pretty fast within the first 1 to 3 years in terms of that thickening. And then it does tend to slow down. These people will be more sick. And that was certainly, the experience that I had when I was at Northwestern is those were the really sick patients that would come in with diffuse scleroderma. Those people are at a higher mortality rate and interstitial lung disease, renal failure, like kind of this diffuse GI disease can all happen as well as even a myocardial involvement. Those patients, they're associated with the SCL70 antibodies in terms of their lab workup.
Thank you. That's a really great review of the disease itself. I don't think we often think about looking at patients' hands in pulmonary, right? I know you guys are all over them when they come into rheumatology. But in pulmonary, we're looking at their respiratory, we're just observing a patient. We're looking at their respiratory effort and rate and, can they have a conversation without being too breathless? And are they coughing? But I remember very early in my career, I had a physician say, always look at their hands. Always look at their hands. And of course, we're looking for clubbing and, things that you just very much associate with the lung disease itself. But those autoimmune diseases love to show up in the hands, don't they?
They very much do. And it's funny. When I first meet someone, that's often one of the first places I look at someone's hands. And even, obviously when I go to like shake their hands, I try not to do it really hard, but it's often a big clue as to really what that person is there for.
I like that clue of like the loss of the wrinkles and that type of
Mhm.
thing. All right. So, Jessica, when you have a new ILD patient, it's your first date that you know they have ILD, and you are starting to think just some differentials of why you think this patient has this ILD. What are red flags to you that stick out that make you think this could be scleroderma?
Yeah. Yeah. And I think, Amanda did such a good summary, and I'm going to reiterate some of the things that she's already mentioned here. But, sometimes people like Amanda make it really easy on us because they come to us from rheumatology. They already have a diagnosis. So that makes it pretty easy on us. But what happens when it's more lung dominant, when patients might have the lung features even before the systemic features of a connective tissue disease, or I think now it's SARD. Is that right, Amanda? Systemic autoimmune rheumatic disease. That's our new terminology there. But, oftentimes at the tertiary center where I work in, when I have a new ILD patient, they may have a CT already. And so I've already looked at that CT before I've gone in the room. And if I see certain patterns on their CT, something called NSIP, nonspecific interstitial pneumonia, or organizing pneumonia, that right at the start puts, even before I've seen the patient, that puts them right at the top, autoimmune disease at the top of the list. And then demographic wise, if I see they're a young or a middle-aged female, that really then pushes it up even more because it's more common with kind of younger and middle-aged females. So already I'm walking into the room sometimes knowing, hey, this person I'm pretty sure is going to have an autoimmune disease. So as soon as I walk in, just like Amanda said, I'm already doing my physical exam. I'm already looking at their face. I'm looking at their hand. I'm looking at their skin. So we're really, going into their history and their physical exam to kind of find those little things that make me suspicious of an autoimmune disease or specifically a scleroderma. And so, a lot of those things are, yes, the things that Amanda talked about. So, asking about Raynaud's phenomenon. Do they have digital pitting of the fingers, ulcers of their fingers? Do you have sausage fingers or puffy fingers? I always think sausage fingers is a funny term, but if you see a sausage finger, it does look kind of like a sausage wing. Or that tightening of the skin in the hands. They can have sclerodactyly, so decreased range of motion of the hands. You see in their face, they can have more of a mask-like kind of appearance to the face and tightening. They can have kind of tightening if you kind of pinch their chest or their arms and their legs. And then, looking at their skin, telangiectasias, other complaints like GI complaints. So a lot of people with scleroderma also have their GI system very much affected. And again, Amanda talked about a lot of these, but dysphagia, esophageal dysmotility, weight loss, any changes to their bowel. And then I also look at, kind of other things that I have on hand, like their PFTs. Do I have suspicion of pulmonary hypertension based on some of the things that I can see or their history? And then on top of that, I'm always looking at kind of like, is there an overlap syndrome here? Because scleroderma can overlap with myositis or other types of autoimmune diseases. So even asking about muscles and the sickness symptoms and other things like that as well. So we like to fancy ourselves in ILD as like little mini rheumatologists. We try our best. But yeah, I mean, a lot of things you're looking at and talking to with that patient about.
Thank you for that. That was really good. Amanda, so let's say that the two of you work together, rheumatology and the ILD centers. I know I'm in private practice, and so I have to call to get someone scheduled, and I don't have very great access. But I know in a lot of centers, you guys work together. So Jessica now sends this patient over to you, suspecting an interstitial lung disease. She's suspecting scleroderma specifically. What are the confirmatory testing that you would want to do to say, okay, this for sure is scleroderma?
Yeah, I mean, we're fortunate that a lot of our diseases have specific antibodies that are really linked to that particular disease. And so, as I kind of said, really it's that ANA test. And specifically, if I'm questioning scleroderma, there's actually a scleroderma panel that you can run. And so I will often run that. And again, if I see somebody that's got SCL70 antibodies, I'm really more suspicious for diffuse scleroderma. RNA polymerase antibodies, that's a big one, because if you see that, those patients tend to, again, be more sick. Those are the patients that can develop scleroderma renal crisis, have a more progressive ILD. And so I'm always, pretty nervous when those come back positive. And, again, if they have centromere antibodies, I'm really more thinking, more of that cutaneous, that limited type of scleroderma. So really the antibodies can really guide you in terms of what potentially the disorder might be. As Jessica mentioned, some people are overlap, right? So they could be mixed connective tissue disease, and those people will have RNP antibodies, or they'll have elevated CKs because they've got some muscle involvement as well. And so that's really where those labs can really help kind of put the picture together. But it's not just one thing. I mean, oftentimes I'm getting consults for like low positive SCL70 antibodies that really aren't. I just had one this week actually in an elderly patient that clearly does not have diffuse scleroderma. So it's really putting all of the pieces together using those labs along with that, NSIP pattern on CT if I was, being referred by Jessica. And, again, it's one of those things that scleroderma, you really, once you start seeing it, you really can recognize it. As Jessica said, with the skin, you kind of look at them, to your point, you look at the hands. These people, particularly with diffuse, will also have kind of a reduced oral aperture. And so I will have them open their mouths. They can't entirely open up all the way. And oftentimes they'll have those telangiectasias. They'll be hiding out on the roof of their mouth. And so I'm really doing a nice job of trying to do a thorough physical exam, so that I can kind of put all of the pieces of the puzzle together.
I like that, looking in the mouth, to the roof of the mouth specifically, to look for those. That's a great key, because I think when we're looking in the airway in general, pulm, we're looking at their Mallampati score, we're looking at, for thrush, we're looking for those types of things, but I don't think we think to look for that. So that's a really good
I think
key.
I'm going to add
Yeah.
that on to my assessment. I wonder, Amanda, do you use nail-fold capillaroscopy at all?
I should. Yes, I really, really should. Yeah, that's on my list of things to no, because it really can be helpful, particularly early on, because if you have a really, really early patient, you may only see those changes if you're doing that particular physical exam.
Jessica, can you explain to everybody what that test is?
Yeah, it's basically just looking right at the nail fold, like right here, the cuticle, under basically what is it called? A capillaroscopy? I don't know.
Capillaroscopy. Yeah.
Yeah. It's like basically a magnification tool.
Yep.
Magnify the blood vessels. And if there's dilation or of the blood vessels and things like that, abnormality of the blood vessels, that kind of shows you that there might be more vasculopathies, vascular issues with that patient, maybe more concern for pulmonary hypertension, but it also just kind of helps with giving you one more point towards that diagnosis of scleroderma. I don't know if I said that exactly correct. Maybe Amanda would know a little bit more.
Yeah.
I don't do it myself.
No, I know. That's just it. That's exactly what it's looking for. Because sometimes that can be the first thing that you actually see, is those subtle changes that you wouldn't otherwise know if you didn't have a magnifying glass. Because, we look at I look at people's fingers all the time, but it's the same thing with the eyes, right? Like I look at people's eyes, oh, okay, your eyes look okay to me. But like then they go to, their ophthalmologist and they've got, something really severe going on, and you really need that magnifying glass to be able to see. But that's one of those early changes, is seeing those, dilation of those blood vessels. And so it's definitely a clue that there's an underlying connective tissue disease at play.
So since we're talking about testing, Amanda, you'd mentioned the antibodies. Is there anything else in rheumatology that you would want to do for that patient as far as like a diagnostic workup for them?
Yeah. So if I, let's say maybe they already have not gone to Jessica yet, I would, as a baseline for everybody, they're going to get, certainly a chest X-ray day one, right? High res CT, PFTs, an echocardiogram for baseline, and then often I'll do an esophagram just because a lot of these people have dysphagia, and most of them, if not all scleroderma patients, will at some point have some kind of motility, reflux, something going on that they're going to probably need to see GI for. And so oftentimes they'll go in for an endoscopy. They'll dilate the esophagus for these patients to allow them to be able to swallow more effectively.
And how about you, Jessica? What kind of testing would you want to do once you inherited them?
Yeah, just echoing what Amanda said. Yeah, definitely that HRCT is probably the most important thing. We need to kind of see the pattern of injury that really helps us to kind of lead us down a path of a diagnosis. The echocardiogram, especially for a patient with scleroderma, we are concerned about pulmonary hypertension. I know this is specifically about ILD today, but that's a really big, a really big thing that we're worried about, especially later on in disease. So ILD tends to crop up a little bit earlier for patients in the course of their scleroderma, and PH a little bit later, although that is not always the case, So echocardiogram, HRCT, and the PFTs. PFT is the pulmonary function testing, both really the FVC and the diffusion capacity is what we're getting on a regular basis. And that's to know how severe, their physiology is impaired, but also to help monitor over time and help us with treatment decisions and if things are getting better, worse, or the same. So those are kind of the big ones from our standpoint.
Okay. Well, moving on to treatment. Now you've decided this patient has scleroderma related to ILD. Amanda, what would you want to see for treatment in this patient?
Yeah, it's interesting. I tell all of, as soon as you diagnose scleroderma, right? Like patients are going home and they're, Googling it, and often they'll say, oh my gosh, I have 5 years to live, right? I mean, and in some of the older data, particularly if they had like scleroderma ILD, I mean, it was pretty grim. And so I really try to lay a framework for patients initially is, hey, you know what? We treat what we're up against here. So, and I say that to every single patient. So if your biggest issue, like maybe you don't have lung disease, but your biggest issue is your reflux, like, well, we have to address that. I tell every single patient they need to be sleeping with the head of their bed elevated. And then I'm just talking like some pillows, like they have to get a wedge, right? Because we certainly do not want that acid to go into the lungs. And so, I try to really think about those things too. You have to stay well moisturized. You have to, really moisturize hands, feet every single day, because if you get cut, you don't have proper circulation, you're going to get, unfortunately, probably an ulceration, and then, could lead to potentially even amputations. And so it's really improving blood flow. And so oftentimes in terms of treatment, we're addressing those things, right? Like I'm putting everybody on a calcium channel blocker. I'm putting them often on a PPI. I'm doing those things. From an ILD specific perspective, oftentimes, depending on I really do think it's important that we work collaboratively. And I will often initiate mycophenolate, but then I am, obviously doing that in conjunction with the ILD clinic. I'm really fortunate. We have, CU right down the road. And so I will often, refer there. National Jewish is right down the road. So we obviously have them too that we can work in partnership with.
How about you, Jessica?
Yeah, I think the collaboration is absolute key. And sometimes, who's treating, it might depend on what's more dominant. Is it more the systemic symptoms of the disease, or is it more the lungs? But, when we know somebody now has a diagnosis of scleroderma and they have interstitial lung disease, I'm first trying to decide, are they severe enough to warrant treatment from a lung standpoint? So we know that a large number of patients with scleroderma will have some interstitial changes on their CAT scans, maybe even upwards to 80%, but only about a third of them actually have clinically significant interstitial lung disease. And so looking at the PFTs, are they impaired? Are they symptomatic? Is their HRCT show significant, maybe 20% or more impairment of their lung parenchyma? Is it progressing? Or do they fit into kind of that high risk, somebody with diffuse disease or SCL70 and things like that? We love mycophenolate. Yeah, I mean, mycophenolate actually does have some data behind it from the scleroderma lung trials, that it helps with decrease in decline in FVC in scleroderma patients. And so that is definitely our go-to. If things are getting worse despite that treatment, we've got a host of other things we can use. From the immunosuppression standpoint, we love rituximab. Really severe cases, cyclophosphamide we can utilize. And then we have some new things as well that have just come out. So tocilizumab, which is an IL-6 inhibitor, that has been shown to decrease the progression of FVC decline in patients. And then OFEV or nintedanib, which many people know is used in IPF and other progressive pulmonary fibrotic lung diseases. We can utilize that to help decrease progression of fibrosis if we're seeing fibrotic progression. These treatments I do find sometimes are hard for scleroderma patients to manage with their GI issues. So we have to really monitor them a lot. And they sometimes have infection issues too with these immunosuppressants. So yeah, it's a lot to think about with these patients, but we have a lot of different things that we can kind of add on if we see disease progression.
And are you using them in combination or just individually switching to another agent? What spurs you to stack therapies or move on to a different therapy?
Yeah, that's a great question. We always start with immunosuppression. We want to see if, we can treat the underlying disease that is, causing the lung issues. So we start with mycophenolate or maybe rituximab, something like that, if it's more severe. If they progress despite using immunosuppression, and if that progression is more fibrotic, so we're seeing more traction bronchiectasis, more reticulations, more honeycombing in the lung, more architectural distortion of the lung, or that FVC declining, worsening symptoms, things like that. We'll use that as a cue that maybe we should add on an antifibrotic. So then we'll have patients on both immunosuppression and antifibrotic medication.
I imagine there's a little bit of chicken and the egg of what is causing worsening disease when it comes to patients who are also aspirating. So Jessica, on imaging, what tells you this is an ILD flare or this looks like they're aspirating? Is it just for those that are new to looking at imaging maybe, or some keys that you kind of use to say, you know what, I don't think this is necessarily a flare of their disease. I think you're aspirating and we need to focus more on that.
Yeah. So if a patient that's flaring, we'll see a lot more ground glass and a lot more diffuse. So it's throughout the lung. There's really more of that ground glass, which is that hazy look of inflammation. Aspiration, you might see more consolidation. It might be more localized, maybe to the right lower lobe. The lower lobes generally is where you see, kind of that aspiration issue. You can see more of like kind of a tree and bud type of opacities. It looks just like it sounds, like a budding tree in spring. Kind of looks like very white, kind of mucus impaction going on within the lung. Sometimes we can see inflamed airways as well in those patients. So it may be good also to talk to your radiologist because these are really difficult things to parse out sometimes. So that if you have a radiologist that you can go to kind of ask what they think, sometimes it requires that level of understanding of the imaging.
Amanda, to you, what tells you outside of the lungs that their disease is not well managed or that they are flaring or not well controlled?
Yeah, I mean, I think it's obviously some ulcerations to the fingers, the skin tightening is like I said, with diffuse patients, that will often kind of progress pretty rapidly in the first, couple of years and then really slow down. That can be so worrisome for patients, obviously, and we do everything that we can to try to slow that down as well. And but yeah, I would say, it's interesting because again, it is so like, is it the GI system that's going on? Is it the lungs? Is it the skin? It's all of those factors in terms of kind of determining patient's flare and like, do you need to add on, Revatio or sildenafil, for recurrent ulcerations in addition to their calcium channel blocker. So it's really, I think, seeing these patients regularly to kind of see how they're doing, particularly in those winter months where, obviously they can have much more impactful problems with their
Hmm.
fingers and their toes and things like that. The other thing that you all taught me was really the importance of pulmonary rehab, which a lot of my patients, unless they're going to a like ILD center, don't automatically get. And so that's something that I really taken, kind of home with me is that, it's great to give these patients, the medications to hopefully stop the progression of their disease, but then they also need to learn. And again, you know this way better than me, but how to use what they've got still and really, maximize that.
Hmm.
Do you ever refer for transplant, Jessica?
I do. It's a little bit sticky with scleroderma. Sometimes it's a little harder for them because of those GI issues. The lung transplant physicians do not want their new lungs having aspiration getting into them, and so they really they do look at those studies, especially a lot for the scleroderma patients. But yeah, absolutely. I mean, if they've got interstitial lung disease, pulmonary hypertension that is not being stabilized with the medications we're utilizing, they're continuing to progress, we can send them over to transplant and see if they would qualify.
The other thing that I've often been doing is if I have like a new diffuse, I'm really trying to see if I can get, I don't know, Jessica, what your feelings on this are, but I'm really trying to see if I can get them into one of those CAR T cell clinical trials, because that seems like an exciting kind of thing for scleroderma patients in particular. And I've had a couple patients in the trials that have done really, really well. So, I guess to be determined, but
Yeah, we're part of one of those trials, and I have to say I don't know too much about it yet, or how patients are responding to it, but it's exciting.
Are there any other new things on the horizon that you guys are aware of for these patients? Whether it is just generally for ILD or for patients, with maybe mixed autoimmune disorders or scleroderma. Amanda, do you want to start?
yeah, I mean, it's so lovely. I always bring up whenever I'm speaking anywhere, I really age myself because I'm like, well, I've been doing this for 18 years. And, when I first started, we really just didn't have a lot. And just to watch this progression of like the biologics has just been so incredible with these patients. And I think we are starting to get there too, also in our scleroderma patients as well. So I know there's, and Jessica can probably speak more to this, but some of the new antifibrotics that are coming, and you too, Corinne. So that's all really exciting for patients. And then of course, from an inflammatory arthritis perspective, because again, some of these patients have that too. Certainly some new biologics kind of, on the horizon or that they're studying to be used, which is awesome.
Yeah, yeah. So to speak to the new antifibrotic, we do have something on the cusp of being approved by the FDA called nerandomilast. It really is similar to the two that we currently have, pirfenidone and nintedanib, in the way, not in the pathway, but in the way that it doesn't stop or reverse fibrosis, but it helps to decrease progression of fibrosis. Um, but it looks like it will be approved to be able to be added on to the other two. So you could have combination therapy of antifibrotic. You could have it just the nerandomilast only. Um, and it looks like there's not going to be any need for any lab monitoring, and maybe the side effects, based on what I'm seeing in the trials, might be less. So there's less diarrhea side effect than with the OFEV. So especially the scleroderma patients, it's really exciting because they may be able to manage this one a lot better. Um, There are some other things in the works, like the Teton study, which is looking at use of inhaled treprostinil for pulmonary fibrosis, potentially, not just PH-ILD. That should be coming out really soon. We'll see if that, has any positive endpoints there. Yeah, and then there's some other like wild things, which like immune ablation at certain centers, and they give autologous stem cell transplant. It's a little bit more of a risky kind of procedure, only done at very advanced kind of areas and for people with very severe scleroderma. It's really all I can think of right now, like with respect to treatments for scleroderma in particular.
Yep. Thank you so much for that. Well, any closing thoughts, anything you'd like listeners to know about scleroderma patients, scleroderma ILD, that you feel are big takeaways? Amanda, do you want to start it off?
I think it's just important to remember that when you make this diagnosis, this is extremely overwhelming for the patient, and that this is not a death sentence. I have patients that I've had, with scleroderma for many years that are thriving. And I really try to tell all of my patients that, like, you're going to be okay. Yes, there are going to be challenges with this, but we're in this together. And I think having this multidisciplinary team where we actually talk to each other, I think is so crucial. So I love the cross collaboration. I think it is absolutely imperative for good patient care.
Yeah, I think the cross collaboration is absolute key. I mean, is if you don't have that good, rheumatology and GI collaboration with your pulmonary, it might be best for that patient to be seen in a center that can kind of get all of that care. So I do think scleroderma in particular, especially if it's severe, and they've got ILD and maybe pulmonary hypertension, it might be best for that patient to be in a center that is familiar with scleroderma.
I would echo that for sure. I have no problem sending them down. Actually, the person that runs kind of the scleroderma rheumatology side is a friend of mine at CU, and I send all my diffuse to her as well, because again, I don't know what's going on in the clinical trial world, and these patients can get sick, and so I think having that connection, I think, is crucial. Now, obviously, not everybody has that if you're practicing in like rural Idaho or something, but if you do have access to that, I think it's really important.
And I want to point out, Amanda is working on an initiative to get cross collaboration between pulm and rheumatology and primary cares. She's working on a project, so follow her, watch what RAP is doing and what she's doing, because she is working on, I think, a great project of helping us get out of our clinics and meet with other APPs and other specialties. That's a big passion of hers, and giving us all the courage to pick up the phone and actually say, "Can I have your number? Can I text you if I have this patient?" And I know a lot of you that are new, that's a little scary thing to do. Eventually, once you've been doing it long enough, you start bumping into others and meeting others in other specialties and creating those relationships. But Amanda's working on a process to kind of help everyone be able to kind of go to almost like a LinkedIn version for cross specialty for diseases that overlap. So more to come on that. So keep an eye on her. She's doing big things. I want to thank you both for being here. Amanda, I also want to plug the RAP conference. For reference, we're recording this at the end of August 2025. Their conference is going to be in September in Denver at the Gaylord. So I know this is going to be a little bit late for that, but they have a conference every year. It's great. Follow them. They do crossover a lot of information about interstitial lung diseases. So if you're interested in autoimmune lung diseases or just getting brushed up on autoimmune therapies, that's a great conference to go to. Jessica at the Cleveland Clinic, there's a lot of virtual programs that they put on to help with all sorts of lung disease in the Cleveland Clinic, not just ILD. So they're a great source to follow as well. And of course, please like and follow and subscribe to the APAPP podcast. That really helps support us bringing you information like this. So thank you guys again for joining me today.
Thanks, Corinne.
It's been great.
All right. Until the next time.